So thanks very much. Thanks everyone for coming out and for squishing together. This is a very important topic for all of us who work in cardiovascular medicine, and that is managing and preventing sudden cardiac death in our patients. And tonight we'll focus on a relatively new kid on the block for many of us, and that is the wearable Cardioverter Defibrillator, and what role that can play for us in managing our high-risk patients. So here we have preventing sudden cardiac death with the wearable Cardioverter Defibrillator, commonly known as the LifeVest. So just a few of my disclosures and a disclaimer. This is broad informational topic. Apply it to your patient as you see fit. We'll talk about sudden cardiac death and ICDs in general, and then the LifeVest, how it works, feasibility, uses of the LifeVest, focusing really on that post-revascularization population, whether it's post-PCI or post-CABG, also the post-infarct population, a very important subset, and then the CHF patient and what role the LifeVest can play during optimization, and finally additional guidelines and coverage for the LifeVest. So first of all, the broad topic of sudden cardiac death. What is that? That is something that occurs unexpectedly. It's sudden, there's no warning. Death occurs within minutes unless there's an intervention, and it's cardiac in nature. So 350,000 cases per year in the United States. That's about 43 victims per hour. So you can think that in the time we spent together tonight, about 40 people around the country will suffer a sudden cardiac death event. And about 20% survival, unless there's someone there to intervene immediately. The natural trajectory of this is death. So something we'd like to be on top of. Again, it's a leading cardiac cause of death in the United States, and this outshines things that typically scare us, like stroke or lung cancer, breast cancer, HIV, AIDS. Sudden cardiac death, is much higher than any one of those, and most of them combined. 80 to 90% of these are due to tachyarrhythmias, either ventricular tachycardia or ventricular fibrillation. The heart's too fast, it's asynchronous, there's no effective cardiac output, no circulation, and you die. 10 to 20% are due to other things, like an acute MI. If you have a massive infarct where there's pump failure, the muscle's just too infarcted to beat, obviously you'll succumb to that, and that's also sudden cardiac death. And then we have to remember, too, that the heart can go too slow. So there can be bradycardia or asystole, and this can also be a subset of the sudden cardiac death patients. So again, in arrhythmias causing sudden cardiac death, ventricular tachycardia being the most common, also VFib, torsades, which is a subset of VT, and bradycardia, accounting for 17% of those events. So we think the LifeVest will protect our patients from the tachyarrhythmias, which is the vast majority. There's also the very slow arrhythmias that can be a problem. And in that setting, the LifeVest can't pace you, but it can advise the bystander that this person does not have a rhythm and they need CPR as opposed to just defibrillation. So, the LifeVest does have a role in helping us manage those patients, and without a monitor, there's some rhythm identification there that we can benefit from. So we say, why do sudden cardiac death victims have VT or VF? Coronary disease causes 80% of sudden cardiac death episodes in Western countries, and this can be the first evidence of CAD in women, 63%, and even 50% of men. So you didn't even know you had coronary disease. Now you've had a sudden cardiac death episode, and that's what leads to the diagnosis. So it's this sort of catastrophic event that precedes even your awareness that you may have that, making the whole topic just that much more scary. And what happens? So you have an artery, plaque develops, the plaque is stable, and then there's a stressful event and the plaque ruptures. Thrombus forms, and then a vessel that was only mild or moderately obstructed becomes 100% occlusion. Downstream muscle has no oxygen. The infarct occurs. That's electrically destabilizing. That can precipitate the arrhythmia. Or if you survive the infarct, that infarcted muscle now forms scar, and that scar becomes a focus for abnormal electrical activity. Or there's ischemia surrounding that scar, which forms a very arrhythmic substrate, which leaves our patients somewhat vulnerable for as long as that remains the case. So this is the disease process which is culprit to this issue of sudden cardiac death we're here to talk about. So how do you treat sudden cardiac death? go for the cause. We treat coronary disease. We revascularize when it's possible. We give blood thinners to prevent that clot formation should a plaque rupture. We try to modify all the risk factors: hypertension, diabetes, smoking, stress, inflammation, diet, exercise. We get all that optimized. We promote recovery of depressed ejection fraction, which is a major risk factor. So we're giving the beta blockers, the ACE inhibitors, the L-dactone, promoting electrical quiescence with the beta blockers or with antiarrhythmic drugs, amiodarone, mexiletine. These are the players we use for the ventricular arrhythmias. And then we have to realize that that isn't enough, and we protect for breakthrough ventricular arrhythmias with implantable defibrillators. Historically, those are always transvenous, under the skin, lead into the heart. Now, and you've seen them in our hospital, the subcutaneous defibrillators sit under your skin on the side. Everything's outside the thorax, lead up the front, gives you ICD protection. Our hospital, we are the leading hospital for subcutaneous ICD implants this year in the entire Boston Scientific territory in Washington. So we've all had more exposure than many of our colleagues to these. And then finally, if somebody doesn't quite qualify for an ICD, or we're still deciding, or it isn't time, there's this possibility of wearing a LifeVest. A vest, like a bulletproof vest, fits snug to your skin, provides you with ICD protection until you're ready for your ICD implant or until you no longer need your ICD implant, whichever the case may be. So that's where all of this is going to lead us here. So briefly on the topic of ICDs, we say with sudden cardiac death, are we protecting those at risk? So 300 events a year. Most of those events will occur in the general population and those at high risk for coronary disease who have never had clinical events. So those patients who as individuals are relatively low risk will in fact account for the majority of these episodes. As your coronary disease burden increases and you've had events and your ejection fraction starts to drop, then we identify individuals who are very high risk for this, and they in fact meet guideline criteria for ICD implant. We still have to recognize that this represents just a small fraction of the number of individuals who are actually going to suffer that sudden cardiac death event. So we can protect those few people who are super high risk, recognizing that we're leaving a large number of people unprotected. And why? Because we can't identify who they are. So this is a background for our topic. When do we consider an implantable defibrillator? Primary prophylaxis when the ejection fraction is less than 35%. That's an ischemic or a non-ischemic cardiomyopathy, and that's despite revascularization, medical therapy for 3 months, or at least 40 days after a myocardial infarction. Then you become eligible. The question is, what do you do while we're in those waiting periods, the 3 months, the 40 days? If you have a high-risk individual, we'll see the LifeVest has a role in that setting. And then obviously those who have had a sudden cardiac death event, they've had a VT or a VFib arrest, without an obvious reversible cause, these people qualify for ICD implantation, and we're not required to wait. So once again, guidelines fail the majority of sudden cardiac death victims because they don't identify the vast majority of people who are actually going to suffer an arrest. So we can think of that iceberg representing all the people who will have a sudden cardiac death event this year. Everyone below water is outside ICD guidelines. Everyone above water is at least within ICD guidelines. And still we recognize that perhaps 20% of patients who meet guideline criteria for defibrillators will actually go on to receive one. So the population remains relatively unprotected, either because we can't identify them or we're not referring them, encouraging them to have ICD protection. Our ICD strategies, historically it's the transvenous ICD, and this is what we're all familiar with, and that's the device on the left. It sits subcutaneously above your left pec in a tissue pocket, and you have a lead through the venous system into your heart. This can provide pacing if you have bradycardia. It can provide anti-tachycardia pacing to try to pace you out of your VT before it delivers that shock therapy. And more recently, we have the Boston Scientific product, which is the subcutaneous ICD. The whole thing sits outside your thorax, so the ICD is sitting under the skin on your side, posterior enough that if you place an ICD lead under your skin and up the front, you'll sandwich enough myocardium that that system can shock you into normal rhythm. And that device does work extremely well, and the discriminators for SVT or inappropriate rhythms also work exceedingly well. So that's a new technology that we have available to our patients who don't need any bradycardia pacing and have a narrow QRS. So the chance that they'll ever need a resynchronizing device is low. And we've implanted a number of very young people with this device, and it's ideal for them because it leaves the hardware out of the body, out of the blood vessels, out of the heart for as long as possible in that person. So we've implanted a number of 20-year-olds, a number of 30-year-olds with this device, and you're like, if we can buy them 10, 20, 30 years without anything going into their hearts, you know, we're doing them, I think, a tremendous favor. And this also sensitizes us to the fact that effective defibrillators don't have to be inside your body, which is exactly what the LifeVest is doing. It's perfectly acceptable to have something outside the thorax that can provide you with ICD protection. And that's what the LifeVest does. And with all of our uses of the subcutaneous defibrillator, it's easy to imagine that that's going to be effective technology. And in fact, it's very good. So there again, on X-ray is a transvenous ICD and then also a subcutaneous ICD. The thick part on the lead is the coil, so the shock would be between the can and that coil, and both of those passing a lot of energy through the myocardium and able to set your rhythm to zero. So what are the role for the LifeVest? The roles are all those scenarios where patients aren't yet eligible for ICDs. So if you're waiting in a waiting period, 3 months, and that's a CMS definition, not necessarily a medical definition, post-PCI with a depressed ejection fraction, post-CABG with a depressed ejection fraction, or you have a new diagnosis of a low ejection fraction, we didn't know you had it before, CMS says you need 3 months of good medical therapy for your EF to improve before we implant you. So we're stuck with these waiting periods if we want to get reimbursed. You know, it's a guideline, it's a regulatory thing rather than a clinical thing. So we wonder about protecting high-risk patients during that waiting period. Or if you have had an MI, we are obligated to wait at least 40 days before implanting you with a defibrillator. And there are trials, the Dynamite trial and the IRIS trial, that showed that early implantation of an ICD in that setting doesn't have a mortality benefit. Why? Because enough of those patients die of pump failure such that the ICD doesn't benefit the overall population. But what about those patients who don't die of pump failure and are high risk during that waiting period? Do they deserve some protection? And here we see a niche for the LifeVest. And then a variety of other medical conditions. You have a depressed ejection fraction, you're awaiting revascularization, you're high risk. Or you have a history of VT storm. We're not controlling your rhythm yet. We want to have good control before we implant you with the defibrillator so you don't just get tons of shocks. If you have New York Heart Association Class 4 heart failure is so severe, we're not supposed to implant you. So we try to medically optimize, raise you to a Class 3 when you do become eligible. If your prognosis is less than a year, we're not supposed to implant. Someone may want protection during that 1 year. The LifeVest plays a good role. Or for those waiting for heart transplant. And then there's always just scheduling and personal issues. Someone needs to travel, go to a wedding. There's lab or OR availability. They have an infection you want it to clear. You know, there's a role for a LifeVest in all of those settings, peri-ICD. So LifeVest function, compliance, efficacy. How does it work? This is what the LifeVest looks like. So it is a vest. There are 4 electrodes with 2 monitoring channels. If the device is preparing to shock you, it will release gel to improve contact. It's able to deliver 150 joules of biphasic energy, store all of your electrograms, and there's a response button. So this is an interactive ICD. An implantable ICD, the patient can't interact with it, but if you have a LifeVest, the patient has the option to abort a shock if they feel they don't need it, or it may be inappropriate, or they're hemodynamically stable even if they're in a real rhythm. And that's a very nice feature which we gain because we have lots of room to play with battery expectancy in the LifeVest. You can recharge it. An implantable defibrillator you can't recharge. You want to change it as infrequently as possible. So there's all these tricks and shortcuts or things we do to minimize battery drain on an implantable defibrillator. And one of those things is the patient can't interact with it. The thing can't yell out to the patient through a microphone that they're going to get a shock or that someone should do CPR. Whereas with the LifeVest, with the rechargeability of the battery, you don't have these limitations and the device becomes interactive. And that becomes really interesting. If the patient has a symptom, they can press the button, it'll record. Or if the device is going to deliver therapy, it will warn the patient, and the patient has the option to abort that therapy if they don't feel that it is necessary. So there's just a few more pictures of how the device fits, how it can look, so real-world experiences. In general, it can be very well tolerated. We have one of our star patients here who wore a LifeVest for 10 months, and at the end of the talk, he's going to just tell us a little bit about what that experience was like. But the feasibility of the LifeVest is improving. And the next thing you kind of want to know is, do people actually wear it? You give it to your patient, do they actually wear it? So that has been demonstrated in a number of studies. Here's the Cleveland Clinic registry, over 2,000 patients, showing that hours per day, there is good wearing of the LifeVest up to 120 days of use. And in fact, the longer you're supposed to wear it, the more your compliance grows. So as we approach 30 days, 40 days, 50 days, in fact, the hours per day that the patient wears the device tends to increase. We also see that in the Wear It 2 registry that I'll talk about later. Here's 2,000 patients. Average wear time is 90 days. An average of 21 hours per day the patient's actually wearing the device. So we can believe that if we give this to someone and convince them to wear it, that they will in fact wear it the vast majority of the time and receive the protection that we have intended for them. And then you want to know, well, does it work? And that, the Cleveland Clinic registry data also gives us good information about that. 3,500 patients. There were 17 deaths due to bradyarrhythmias asystoles. The LifeVest can't treat you for those. That's 0.6%. But in 59 patients, there were 80 VT or VF events, and they were all converted with the defibrillator. In those who were treated, there were 8 deaths for recurrence of the arrhythmia, and patients were very ill. In one of those, the bystander pressed the button to abort the therapy, and the patient needed the therapy, so that's unfortunate. Instruct those around you not to interfere. And then sometimes when you fall with syncope, the contact electrodes that sense the arrhythmias can be disrupted. And now the LifeVest isn't sensing you appropriately, and that was a reason to succumb. So the contact and the redundancy of the electrodes has improved in response to these things. So we expect all of that to be better. Survival in 90% of VT-VF events and in 73% of total events. What's important is that for all the arrhythmias the device detected, it successfully shocked the patient out of that rhythm. So the device does in fact work very nicely. This is the alarm sequence. This is what happens if you're wearing it and you have an arrhythmia. So you get an arrhythmia that's detected. First of all, there's a vibration alert, and that's going to continue. Then a siren alert begins that continues through the sequence. The siren gets louder. The patient gets an audible prompt, so the device speaks to you. It sounds kind of like the voice of God, and it says, I've been on the phone with the patient with a LifeVest, and the thing's screaming in the background, that it says, electrical shock possible. As it's preparing, it releases gel to improve contact. Then it instructs the bystanders, do not touch the patient because it's anticipating that it needs the shock. And then boom, it'll deliver the shock unless somebody pressed the button to stop that shock. That's the sequence of events that occur, and here's some published examples of the LifeVest delivering therapy, both in the settings of ventricular tachycardia and a much finer rhythm of ventricular fibrillation, and the lightning bolt is when it delivers that shock. So those rhythms go, boom, they're terminated. The device can give Brady pacing. It cannot give Brady pacing. Does it give Brady pacing? No Brady pacing. So you need to recover your spontaneous rhythm, but that typically occurs. How do we program these events? these devices. A VT zone, for example, you pick 150 beats a minute is your VT zone. Any rhythm in the VT zone, it'll be 60 seconds until the first shock. So the charge begins after 15 seconds of the arrhythmia, and then the shock will be delivered 45 seconds later, with the device continuously reconfirming the presence of the rhythm while it's charging and waiting to deliver that therapy. So should the rhythm stop, the device will see that it stopped and it won't deliver therapy. But should it be continuous and the patient hasn't prevented the shock, it will deliver. It's speaking to the patient the entire time, inviting them to stop the rhythm if the shock is not desirable. So that's the VT zone. You can program a VF zone, so say you pick everything above 200, and here the device is going to move faster. So 25 seconds to the first shock. It begins to charge after 5 beats at that rate cutoff, and then the shock will come 25 seconds later. And again, there's the continuous reconfirmation with the device speaking to the patient during that time, but it'll shock much more quickly. And you can program those zones based on what you know about the patient and their clinical rhythms. If they're having recurrences of the rhythm after the shock, the device can give stacked shocks, up to 5 shocks 20 seconds apart if no termination has occurred. And of course, it's reconfirming with that and inviting the patient to abort the sequence if that's desirable. So you don't have to go through the whole 60-second reconfirmation thing if the rhythm didn't terminate or if it immediately recurred. Other aspects of the functionality which are convenient is automatic detection. So any arrhythmia within the cutoff zone, it's going to automatically record in telemetry and report to you. So you get this diagnostic information, be it non-sustained VT or SVTs or AFib with RVR. You can learn a lot about your patient's rhythm without the device delivering therapy. We've talked a lot about the manual response button. You push and hold the button for 3 seconds if you have a symptom, and the device will record 30 seconds prior to that and 15 seconds post. So you can get symptom rhythm correlation. You're having symptoms, you want to know what's going on, you press the button. That is recorded by the device, reported to a database. It's available for the doctor. So AFib, PVCs, PACs, pauses, anything that's going on, you can diagnose with the help of the LifeVest. 75 minutes of stored telemetry per 24 hours, and then when you're in bed next to your transmitter, it automatically uploads to the transmitter, gets pushed to a website, and it's available to the doc. And then that counter resets, and you get 75 more minutes of stored data for the next 24-hour period. So lots of recording ability, and again, that's available because we are not limited by battery, because the battery is rechargeable, which is a big difference from an implantable defibrillator where we can't interact with the battery at all. So let's go to specific scenarios: early sudden cardiac death risk management, post-PCI, and post-MI. 2 very common scenarios that have subtle differences. First of all, post-MI. We learned in Made It 2, one of the big primary prophylaxis ICD trials, demonstrating the benefit of ICD in preventing sudden cardiac death, that ICDs are efficacious in reducing death. 12% at 1 year, 28% at 2 years, 28% at 3 years. And remind ourselves that to be eligible to enter Made It 2, you had to be at least 1 month post-MI if you were not revascularized, and at least 3 months post-revascularization just to qualify for the device. Then it goes to show benefit. So we see again that there's that gap. What about those people waiting to become eligible to enter the trial and maybe having events? So we'll start to hone in on those in both of those contexts. What is the likelihood of sudden death post-myocardial infarction? And the Valiant trial studied this for us, and it found that first 3 months post-myocardial infarction is in fact very high risk. That's the strip in yellow, and the risk is greatest for those who have the most depressed ejection fraction. So post-MI patients with heart failure have 4 to 6 times greater risk of sudden cardiac death in the first 30 days post-MI. 83% of episodes occur after hospital discharge, and 74% of those resuscitated in the first 30 days go on to be alive at 1 year. So that post-MI patient, the more depressed the ejection fraction, the higher risk of a sudden cardiac death following the MI. So in that waiting period to qualify for a primary prophylaxis ICD, we really should be thinking about the risk that our patient has during that waiting period and considering covering them with a LifeVest during that time. If you're out of the ICU and fine, the chance of you succumbing to pump failure is pretty low, and really the risk remaining for you is that arrhythmic risk. And we need to think about protecting our patients in this context. So sudden cardiac death early post-MI is large. Again, like we said, no mortality benefit from ICD implanted within the 30 to 40 days post-MI. 2 trials demonstrated that for us. Again, that was because of pump failure. And we ask ourselves, would an ICD benefit subgroups of that early post-MI? And since we don't know who those people are necessarily, how about thinking about the LifeVest during that mandated waiting period? So again, post-MI, this is from the LifeVest registry published by Andrew Epstein in JACC in 2013. And again, his objective was to use that database to examine the utility of wearable cardiac defibrillators in those high-risk patients in the post-MI setting. He studied over 8,000 patients through the registry, follow-up through the Social Security Death Master File to see how effective the LifeVest was during that period. So here we have patient characteristics. Mean wearable cardiac defibrillator use was 31 days on average. Median daily use was 22 hours. Age was about 63, mostly male. Revascularization post-MI occurred in 62% of the patients, and the average ejection fraction was about 24%. So severely depressed, some revascularization in about half. These are all post-MI. And he found 75% of treated patients received therapy during the first 30 days post-MI. And that was 1.6% of all patients required some treatment by the LifeVest. So that 1.6% of that 8,400 received therapy, and of those that received appropriate therapy, 75% were in the first month, and then 17% in the second month, a little bit less in third and fourth months, and out we go. Median time to treatment was 16 days from the MI. Those who were revascularized, it was 14 days. 96% received therapy in the first 3 months of that 1.6 who did receive therapy. And this resulted in a post-event survival of 91%. 95% of those revascularized survived, and 84% of those with no revascularization survived after receiving appropriate LifeVest therapy. So really identifying that very high-risk time period, early post-MI, prior to patients qualifying for the ICD, and a time when we really should be considering use of the LifeVest. We'll move on to a second subset. This is post-PCI. So these patients are being revascularized, but they have not necessarily had an infarct at this time. So here we study low EF patients scheduled for PTCA. We know that they are at risk for sudden cardiac death. In some studies, 10% of pre-procedure PCI patients may experience an arrhythmic event. So we recognize that these are high risk. And then we acknowledge that for multivessel coronary disease, this may involve multiple trips to the cath lab to complete revascularization. You can have the infarct-related artery, and often a second procedure of a non-infarct-related artery, which may be performed 4 to 6 weeks later. And at least according to some data series, 60% of patients will have multivessel disease. So we think about the LifeVest to protect high-risk patients awaiting PCI or undergoing stage procedures who are at high risk while they're stepping through their therapies. So That was pre-PTCA. How about post-PTCA? So low EF post-PTCA patients are also at risk for sudden cardiac death during their recovery from revascularization. 6% of patients may experience VTVF within 30 days after PCI, PTCA in some data series. And in the highest risk group, which is 20% of patients, most mortality occurred in the first 90 days post-PCI, when we are waiting to evaluate the appropriateness of ICD implantation. And we know that the post-PCI ejection fraction is an independent predictor of all-cause mortality. So we have to think if somebody comes to us with ischemic cardiomyopathy, they have a very low ejection fraction, and we revascularize them, we're like, well, we've opened the artery, we've bypassed them, therefore we've ameliorated their sudden cardiac death risk. If that EF is low, that continues to be a very high-risk individual who deserves to be bridged with LifeVest protection while we reassess for recovery of the ejection fraction in response to that PCI over the next several months on optimal medical therapy. Mortality post-PCI over 90 days has been evaluated in a number of studies, and there's people here who are more familiar with these data sets than I am. But we have the Kennewick trial, 90-day mortality 11%, and they all tried to identify different mortality predictors. There was the Cleveland Clinic registry, and the Cath PCI NCDR registry said it particularly for STEMI patients, 32% mortality in the first 90 days following revascularization. So they continue to be very high risk in that early period post-PCI, and we should be aware of that. For example, the Kennewick trial tried to identify with the scoring system those risk factors that would identify particularly high-risk patients for sudden cardiac death. And we see that if your ejection fraction is depressed, you out of the gates you have a score of 4, which will get you a score of 6, placing you in a very high-risk category with only a few other risk factors present. For example, if you're age above 65 and you have low ejection fraction post-PCI, you are a very high-risk individual for mortality. So freedom from death, as your risk score by the Kennewick scoring system increases, your mortality rates really become very high. And we have to think that patients in this scenario need to be protected while their myocardium is recovering. The NCDR registry, again, I showed it to you, 32% post-STEMI. Risk factors, multiple risk factors associated with high mortality in that patient. So the person who has come in with an ST elevation MI, we have revascularized them. Supposedly they're all wide open. The EF is low. These people are super high risk, and protection should be considered. Again, the Cleveland Clinic post-PCI registry identifying individuals with EF of 26%, a number of risk factors, age 62. The use of the LifeVest in protecting these individuals, 85% lower mortality at 3 months in the LifeVest group compared to the control population who, sort of standard of care, weren't receiving any protection during that time period. So we've looked at a lot of registry data, post-analysis data. How about prospective data? Data that we collected moving forward, and this really was available to us through the Wearable registry, which we've had since 2014. So here's 2,000 patients in the US, also Europe and Israel, data collected up until 2014. It's managed by Arthur Moss, the individual who ran the MADE IT trial, so very familiar, involved with ICD research. We have ischemic cardiomyopathy in 40%, non-ischemics in 46%, and congenital or inherited in a small fraction of those. The Wearable registry, here's clinical characteristics. Females not well represented, all low EF, high burden of heart failure symptoms, a number of other risk factors in the registry, and we see any sustained VT or VF, 2% of those patients experiencing those significant arrhythmias. And then therapies actually required by the defibrillator, 1%. Non-sustained arrhythmia is also highly present, and then a variety of additional rhythms, which the LifeVest can help us detect, certainly were present. And, as we've identified previously, all of these patients are at risk as well for asystolic events. The LifeVest can't pace. It can advise you that there is no rhythm and that CPR can be performed. So good prospective data from the Wear-It2 registry on the usefulness and the efficacy of the wearable defibrillator. Inappropriate treatments exceedingly low. Why? Because if the patient doesn't want the treatment, he has the option to stop the treatment. And death with the wearable defibrillator also very low. And for those patients who did die with the wearable defibrillator, the detected rhythm at the time of death was asystole. There was no death related to unsuccessful termination of VT or VF in that population. So we can compare again the Wear-It2 registry in that first 90 days waiting period, risk of VT, VF 2% at 3 months, and we can compare that data to the MATED RIT ICD patients, which looked at high rate cutoffs, long detection times, very conservative ICD programming, and realized that that was a 1% rate of arrhythmias at 3 months, and those being the patients who have already passed those waiting periods to receive their permanent devices. So in that early period, sort of a 2% risk, and beyond that with very conservative ICD programming, kind of a 1% risk. And it's interesting how those two data sets feed into each other. An interesting question that we'll all ask ourselves is how many patients who have been revascularized with low EF will actually improve their EF to where they don't qualify and supposedly need ICD protection. And the Wear-It2 registry provided us with that. 41% of patients in that registry demonstrated an improvement in their ejection fraction such that they did not receive an ICD. 42% of patients in that registry did receive an ICD. So it was kind of like half recovered enough that they didn't need it. And certainly those who would go on to need it were, probably those who benefited the most from wearing the LifeVest during that waiting period. Interesting too is in the Wear-It2 registry, the detection of VT and VF facilitate a decision for an ICD. So detection of sustained VT-VF in patients that did not require treatment, so they didn't need a shock, but the device telemetry documented a prolonged rhythm, which was concerning enough to any of us to say this person really should be protected by an ICD, resulted in a high percent of these patients actually going on to receive an ICD. So patients receiving an ICD, those who had treatment for VT-VF, 80%, not surprising, the device had to shock you. Now you are out of primary prophylaxis indication into a secondary prophylaxis indication, and they should be implanted. But also sustained VT-VF not receiving treatment as much as 60%, and finally those with no arrhythmias, 30%. So the telemetry data available through the LifeVest also facilitating decisions for implantable devices. And the final population we said we'd talk about, and this is very quick, is the heart failure population. 5 million Americans have heart failure. That's 600,000 new cases per year. 5-year mortality for heart failure is 50%. In people diagnosed with heart failure, sudden cardiac arrest occurs 6 to 9 times more than the general population. And as we all know, we have more than 1 million heart failure hospitalizations per year, and this is a leading cause of hospitalization in those aged above 65. And we, in our clinic, we're starting an entirely new heart failure initiative to try to optimize these patients in the outpatient setting, keep track of them, prevent those heart failure exacerbations and admissions. So it's a big problem, and it is a big problem. High mortality rate and significantly higher risk for sudden cardiac death in the heart failure population. So there's several trials and registries, CHARM, Merit Heart Failure, documenting or giving us number on 3-month mortality and 1-year mortality due to heart failure. And we see that both of those are significant. Sudden cardiac death accounting for 50% of total mortality in heart failure, with ejection fraction being the most important discriminator. So there's total mortality in light blue versus sudden cardiac death mortality in dark blue. And we see across heart failure trials that sudden cardiac death in that heart failure population is substantial. We're in waiting periods. We're all trying to optimize medical therapy. The guidelines say 3 months of optimal medical therapy before we consider permanent ICD implantation. I think sometimes we're at risk of saying, oh, the person started beta blockers 3 months ago, therefore they've been optimized for 3 months. We should realize that's probably not the case. In fact, it can take 8 to 12 weeks to titrate up to a truly therapeutic dose of medical therapy, at which time really the clock should start to tick for that 3-month period on optimal medical therapy, where we wait for the ejection fraction to improve. And we realize during that time that that patient is high risk. The mortality benefit across heart failure trials with beta blocker therapy, for example, really did start to diverge at the 3-month mark. So during that period of optimal medical therapy, the patient has the death risk similar to that of not being on medical therapy at all. So we start beta blockers, we send the patient out with their new prescription, and we think they're protected now because we have them on good medical therapy, let's just see if they recover. Probably not true. The mortality benefit not coming for at least 3 months on good doses of those medications. So we have to titrate patients up to those doses and then wait to see if recovery does occur on those doses, and then acknowledge that while we're undergoing this process, we have someone very high risk sitting in front of us who may well deserve protection with the LifeVest therapy. So we can conclude that the LifeVest wearable defibrillator can be used as a part of a strategy for managing patients at risk of sudden death. There's very low rates of inappropriate therapy. It's safe. There's no death actually related to the wearable defibrillator. That's nice. And it's a risk assessment tool. Do we proceed to ICD implantation? Should we extend the use of the LifeVest, reassess the patient? So say someone improves in their ejection fraction a certain amount, but they're not out of ICD criteria, we can give that person the option of going for an additional 3 months of therapy, see if they do continue to improve if they want to, and the LifeVest can provide protection while we're doing that. And finally, we can decide at the end of our waiting period if it's no longer indicated, which case they turn it in, and hopefully live happily ever after. So one barrier to, I think, the use of the LifeVest is right now there's no randomized controlled trial for the wearable defibrillator and its benefit in the waiting periods. So this is being addressed by the VEST trial, which will enroll until fall of this year. So this is post-MI patients with depressed ejection fraction. Outcome will be sudden cardiac death at 90 days. So that trial is in progress. We're just waiting the results. And we have the clinical decision now whether to use the LifeVest, and I think it's a discussion that should be made with each of our patients who are at risk and may very well want protection. So the Heart Rhythm Society has given us guidelines for using the LifeVest during those waiting periods. It's an option for the clinician. It's something they're saying involve your EP in the decision making. So, that becomes me. And I do think it's appropriate therapy. So let's be aware that our professional societies are incorporating this into the treatment guidelines. They're providing us even in advance of control trial data. And then finally, let's be aware of some ancillary benefits that do come with the LifeVest or that we see. Patients become aware of their disease severity. That can be helpful. We identify compliant patients. The person wearing the LifeVest is motivated to stay on therapy, and that's useful information to the clinician. You can increase patient compliance. They're more adherent to their medical therapy. considering what implantation of a permanent device may be like because they're wearing this vest at this time. We get patient retention and follow-up. And then patients get peace of mind. The LifeVest becomes a safety blanket. They know they're high risk, and they get peace of mind knowing they're protected in the presence of the LifeVest. Also diagnosis. There's the patient response button for any symptoms. Any fluttering, extra beats, skip beats, whatever they may feel, they can press their response button. That event is recorded, becomes available to the clinician. We kind of call that symptom rhythm correlation, which can help us treat our patients for other non-threatening rhythm disturbances. And then, in the presence of defibrillator, let's be aware that your waiting period status can change. So if you're waiting, because you're waiting for a primary prophylaxis ICD, but you have a significant episode of ventricular tachycardia during that period, because it's now documented, you can switch out of that primary prophylaxis waiting period to a secondary prophylaxis indication for a device and receive your defibrillator now. So that can be useful in changing the status of the waiting period. Very helpful. Insurance coverage. Insurance tends to cover all of those scenarios where you'd like to have ICD protection, but it's not available to you. Acute MI, 40 days, revascularization, 3 months, newly diagnosed low ejection fraction during that 3-month waiting period, heart association class 4, you're lifted for transplant, or you have terminal disease with an expectancy less than 1 month. All of those are no permanent ICD. The LifeVest is covered. So in those scenarios, we can reach for this tool. Clinical status delays or prohibits the ICD. You have an illness, you have an infection. You want these things to resolve prior to implantation of the permanent device. The LifeVest has a niche there. You had to remove the LifeVest for whatever reason, dysfunction or infection. You can provide the patient with defibrillator protection while they're waiting reimplantation. All private insurance and Medicare is on board. Medicaid patients, there's a proprietary program through Zoll, and we can talk with our reps to gain access to the device in those situations. So just to finish, and I know you guys have been very good, it's a long talk. We could just look at a couple of our clinical cases in our practice from past months. This is an example of a life save with the LifeVest. I won't belabor this, but this is a 79-year-old male. He has hypertrophic cardiomyopathy, normal coronaries as of 2008, and he had a VFib arrest. He required CPR, cardioversion. He comes into the ICU, he gets the hypothermia cooling protocol, and his mental status is preserved. So now we have this gentleman, he has a preserved ejection fraction, hypertrophic cardiomyopathy with 2 centimeters septal thickness, LVOT gradient of 80 millimeters of mercury, non-obstructive CAD on repeat cath. So we were debating whether septal myectomy or septal ETOH ablation was acceptable for him or appropriate for him to reduce that gradient. I didn't want to implant an ICD in case it would interfere with any of those procedures. We decided to refer him to the UW to consider these things. The UW decided not to do either of those things, but they did implant him with a Boston Scientific dual chamber ICD. In the meantime, after discharge, he did receive a successful LifeVest shock, which was interesting. Considerable risk. You wonder what's the likelihood of him doing this again. In point of fact, he did do it again. So there is his transesophageal echo showing his septum over 2 centimeters. Those are his septal perforators on the left heart cath. You wonder if you can infuse alcohol into any of them. A little dodgy, was a point of controversy, so we had referred him to the academics for this purpose. And then here is an example of his LifeSave event, and we just go across the pages from left to right. When the device does detect the arrhythmia and says we really have one, the tracing turns red, and you can see leading up to the lightning bolt, therapy is actually delivered and restores normal sinus rhythm to this individual. So, the LifeVest being used in a high-risk situation when we weren't ready to implant the permanent device, resulting in a LifeVest in somebody who did then go on to receive an ICD implant. A clinical case of benefit not necessarily shock, but where we do benefit for the patient having the ICD. Here's a 71-year-old male, prior MI ischemic cardiomyopathy, depressed ejection fraction, presented in a wide complex tachycardia, 200 beats a minute, stopped in the emergency room. He received drug-eluting stents. While he cooled off, we discharged him with a LifeVest. And then the LifeVest demonstrated multiple non-sustained VT episodes, which were hemodynamically stable. The patient was aborting the shocks, but we had all of that telemetry data. And we adjusted his amiodarone therapy, for example, based on the telemetry data of the LifeVest. And because he was left bundle, he went on to receive a right-sided CRT device. So here we have multiple runs of non-sustained VT on his LifeVest, documented for us. Again, not hemodynamically significant, but helps us tailor his therapy. He came to us with a right-sided pacemaker. We upgraded that to a right-sided CRT system, and he's benefiting from that heart failure therapy with ICD protection. A final case of clinical benefit. A very favorite patient of mine, 73-year-old male, rides a Harley, sings karaoke to extend his social life. Hypertension, COPD, kidney disease, coronary disease, 2 drug-eluting stents in 2006. His ejection fraction was 45% last time we evaluated him. He came to the emergency room in January, short of breath, wide complex tachycardia, 185 beats a minute. He was cardioverted. He had a big left bundle. His EF is now less than 20%. Heart cath showed progression of his CAD, 2 drug-eluting stents, discharged with his LifeVest, awaiting ICD implantation while we wait for all those antiplatelet agents to wear off so we can do our procedure safely. His LifeVest is repeatedly alarming. He feels his heart racing. He's aborting the shocks because he is hemodynamically stable, comes into the emergency department with a wide complex tachycardia. He's sedated in the emergency room, and we allowed the LifeVest to deliver therapy for him, restoring normal rhythm. Now we started amiodarone in addition. So here he is in his sustained VT, and if you sedate him, don't press the response button. The device will deliver therapy, converts him to normal rhythm. And he goes on to receive a CRT system implantable defibrillator to provide him with protection as well as resynchronizing therapy for his heart failure. He comes back again to the emergency room following ICD shocks, this time for hemodynamically unstable VT, so he was passing out and received 2 appropriate shocks. We added mixilotine to his amiodarone, and he goes out again doing well, comes back to the emergency room. 2 months later, he's feeling unwell. He has a slow VT at 142 beats a minute. We extended his ATP zones to include that, discharged him home, and to date, no further therapies. Last ICD shock was January 20. And so we hope that he continues to be well and arrhythmia-free as he recovers from his heart failure in the presence of a CRT system. And in spite of all the drama, he remains appreciative and sent us a nice thank you card. So that was nice. So just to summarize, the defibrillator has a high success rate, 95% shock success. There's good compliance over time. Patients really do wear this, and it's optimally used during waiting periods, post-MI, post-PCI, post-CABG, optimization of heart failure medications in those patients who are high risk. So thank you very much, everyone, for coming tonight, and it was such a great class. Really appreciate it.